Good afternoon, everyone. My name is Kathy Vincent, and I'm a former senior deputy with the Alabama Department of Public Health. I'm currently consulting with the Health Systems Transformation Team at the Association of State and Territorial Health Officials, or ASTHO. I want to welcome you to today's Payment and Delivery Reform Technical Assistance Call on applying a public health approach to suicide prevention. ASTHO is committed to supporting state and territorial health officials and their leadership teams in reforming models of payment and delivery services within the transforming health system. With support from CDC, we are working with states and territories to build capacity and strengthen ability to integrate population health activities into overall health systems transformation plans. Today's call is the third in the series of 4, and will focus on how states are tackling the issue of suicide prevention through a public health approach. Suicide prevention is being recognized as an interdisciplinary issue, not exclusively a mental health one. This call will provide more detail on some specific initiatives happening at the state level to prevent suicide among at-risk populations, following an overview of the national landscape. And if you could advance the slide for me, it's giving me a little trouble. Thank you. The objectives of today's call are to highlight the unique role of state health agencies in creating safe and supportive communities and environments, to learn about emerging promising practices and outreach to at-risk populations, and to discuss challenges in collaborating with and coordinating efforts among various professionals and the public. Next slide. So now I would like to introduce our speakers. Ellie Stout, as the Director of Grantee and State Initiatives for the Suicide Prevention Resource Center at EDC, or the Education Development Center, Ellie oversees technical assistance and support services for suicide prevention practitioners in state, tribal, community, and higher education settings, including federally funded grantees. Ms. Stout provides strategic directions for TA to each of these groups, as well as directing specific projects to build capacity in core competency areas like messaging, strategic planning, partnerships, and state suicide prevention infrastructure. With nearly 20 years of project management experience, including 8 years at EDC, Ellie brings expertise and skill to TA and group capacity building, culturally competent work with diverse populations, and strategic communications. Next slide. Okay. Jared Heineman is the Violence and Suicide Prevention Section Manager in the Violence and Injury Prevention Mental Health Promotion Branch at the Colorado Department of Public Health and Environment. Mr. Heineman oversees violence and suicide prevention programs, including the Office of Suicide Prevention, Sexual Violence Prevention Program, and Essentials for Childhood, Creating Safe, Stable, and Nurturing Relationships and Environments project. Mr. Heineman directs the Office of Suicide Prevention, which is responsible for serving as the lead entity for suicide prevention and intervention efforts, collaborating with Colorado communities to reduce the number of suicide deaths and attempts. Statewide, Mr. Heineman also serves as the public co-chair for the Suicide Prevention Commission of Colorado, a commission created in 2014 and charged with setting suicide prevention priorities and expanding public and private support for suicide prevention statewide. Next slide. Melissa Heinen is the Minnesota Violent Death Reporting System Coordinator at the Minnesota Department of Health. Prior to this month, Ms. Heinen was the State Suicide Prevention Coordinator. She is a suicide loss survivor and a nurse with a master's degree in public health epidemiology. She's worked for over 15 years in injury prevention, primarily prescription overdose, poisoning, and suicide prevention. She's worked at the national, local, and state level. She gets really excited when data drives prevention, and I'm sure that'll come out in the presentation. If you have a question during the call, you're welcome to post it to the chat box on your screen at any time. We'll answer these during the Q&A at the end of today's presentation. And at that time, we'll also open the phone lines for you to ask additional questions. At the end of the call, you'll be directed to an evaluation survey. And if you will, please do take a few minutes to complete the survey because we always use the feedback that you give us to help inform future ASTHO work. And so I'm now excited to get to the program, and I'll turn it over to Ellie Stout. Ellie?
Great. Thanks so much, Kathy. And hi, everyone. My name is Ellie Stout, and as Kathy mentioned, I direct grantee and state initiatives for the Suicide Prevention Resource Center, or SPRC. And today I'm going to give you a quick overview of suicide prevention nationally, as well as some broad background on what states are doing in this area to hopefully set the stage for Jared and Melissa to tell you a little bit more about what's going on in their states. Before I get into that, I just wanted to tell you a little bit about SPRC in case you hadn't heard of us before. We've been funded by the Substance Abuse and Mental Health Services Administration since 2002, and we've been housed at EDC since that time, our parent organization. And we're the only federally funded national resource center for suicide prevention. So we have an extensive library of resources, information, toolkits, programs, training, and so forth on our website. And I'll tell you a bit more about that later. As you heard, I lead the team that provides training and technical assistance to SAMHSA suicide prevention grantees, as well as we also work with state suicide prevention coordinators who are not currently funded through SAMHSA. We also work with and provide resources for health and behavioral health care organizations at the national, regional, and occasionally local levels. And finally, we also support the National Action Alliance for Suicide Prevention. This is a public-private partnership involving high-level leaders from different sectors and industries who are working together to advance suicide prevention at the national level. So no doubt you've heard in the news recently that suicide death rates have been gradually rising in our country since 1999. And this chart shows the average of rates for different age and ethnic groups over the past 10 years. So you can see that the death rate looks very different over the lifespan for different groups. The yellow line, for example, has a high top peak in the earlier ages, and that represents American Indian, Alaska Native youth and young adults. And the rate for that group then drops quite steeply through the middle years into older adulthood, whereas the next line down, the blue line, represents whites, and you can see for that population the rate is peaking in the middle years between the ages of 35 and 60. And rates in that age range for white, especially men, have gone up over the past 10 years. And this accounts for a lot of the overall increase in rates in the general population. And finally, I just wanted to point out that for many populations, you see another uptick in older adulthood, especially after age 75 to 80. So that's also a high-risk group for suicide, particularly among men, as we'll see on the next slide. So here I'm trying to give you a sense of the important gender differences in suicidal behavior. The image on the left I know is a little small, but it's basically a similar chart to the one previous, but here we're looking at suicide deaths, men versus women. So men are the blue bars and women are the orange bars. And here you can see there's a really marked difference in death rates, with men dying at 3 to 5 times the rate of women in every age group, and the disparity really becomes even more dramatic in those older adult years. The chart on the right shows you information from SAMHSA's National Survey on Drug Use and Health. And you can see here that the picture for suicide attempts is very different. Here for all ages, and especially from youth through the working years, females are more likely to report having attempted suicide in any given year than males. So just a little background on some of the different groups that are at risk. So the suicide prevention community is relatively young and has increasingly been moving more toward a public health approach in order to address some of these increasing rates at the population level. And the image on your right is a graphic showing the strategic directions of the 2012 National Strategy for Suicide Prevention. And you can see that data is really right in the middle there, the fourth strategic direction. And the strategies in the national strategy are across a spectrum, so both upstream or primary prevention as well as intervention, and even postvention, or what some might call aftercare after there's been a death or attempt. And again, all of these different strategies are aiming at reducing the rates, reducing the numbers, especially among vulnerable populations that are at highest risk. So how do we approach prevention? Well, SPRC has had the good fortune to be able to work with states, American Indian tribes, college campuses, and other kinds of communities for almost 15 years now to support their prevention efforts. And what you see here is the framework of how we conceptualize here at SPRC all that the field has learned in that time and all that we know more broadly about effective prevention. And this is actually a sneak peek of our new website, which will be launched in a couple of weeks. This is the sort of guiding framework for how we're going to be organizing our resources moving forward. So I'm going to tell you a little bit about each piece of this framework. The first component is the comprehensive approach to suicide prevention and mental health promotion. And this really shows that because suicide is a very complex problem, prevention requires a multifaceted response. So these 9 puzzle pieces each represent strategies that together form a comprehensive integrated approach for prevention. No one strategy on its own can effectively prevent suicide. And each strategy that you see represented here represents a very broad goal that can then be advanced through an array of possible activities, so programs, policies, practices, services, etc. And I wanted to tell you a bit about an example of a program that relates mostly to this green puzzle piece of ensuring access to effective mental health and suicide care and treatment, which is the full name of that puzzle piece. And the program I wanted to tell you about is the Zero Suicide Initiative, which is a really exciting new movement in the suicide prevention field that you should be familiar with. Zero Suicide is a framework for providing systematic clinical suicide prevention and care. The name itself emphasizes an aspirational goal of zero suicides among the patients that are under a health system's care. And this approach could be adopted in a variety of settings. It's been used in outpatient behavioral health, in inpatient hospitals, primary care clinics could implement this. But the focus is really about how the individual health system is addressing suicide care for its patients. The approach was derived by the Action Alliance's Clinical Care Task Force, which looked to the success of a few innovators like the Henry Ford Health System. And here you see their very impressive results when they improved the quality of care across their system. They saw a reduction in the suicide rate by about 75% for those enrolled in their care over the course of 4 years. SPRC now knows of over 200 healthcare systems around the country that are implementing zero suicide, and state suicide prevention coordinators in almost 20 states have now started to work to disseminate the approach across the state in health systems, both public and private. So it's really taking hold. And I just wanted to give you a little information on, there's a website which you see in green here on the right, and there you can find an online toolkit for health systems that walks them through each of the 7 core elements of zero suicide. We also have resources for champions, including states who want to promote the approach across various health systems they're connected with. EDC is now running regular academies in states around the country, as well as trainings for individual health systems that draw on our national faculty of experts. And we are seeing some early successes now from the very first adopters of the zero suicide approach, with some impressive reductions in suicide deaths among patients under those systems' care. So coming back to our framework, this is probably very familiar to everyone on the call, so I won't spend a lot of time on it. I'll just highlight that the strategic planning process is a really critical part of the framework for effective suicide prevention. And to mention that we do offer a free online course on our website for communities and planning groups to introduce them to this process, and I'll point you towards where to find that in a couple of slides. The final component of our model is the keys to success. And as you'll notice, several of these are really broad best practices in prevention generally. But there are two in particular that are very suicide prevention specific that I wanted to point out. Engaging people with lived experience relates to people who've survived a suicide attempt or suicidal thoughts, and also to people who've lost a loved one. And it's really critical to understand their input and experience in order to inform what's most promising in supporting and treating suicidal individuals. And then the orange block here, safe and effective messaging and reporting, that's also very important in our field. There is a risk of inadvertently causing contagion, so there's a significant evidence base on safer messaging, both from prevention folks themselves and through the news media. So all three pieces working together form our framework for effective suicide prevention, and that's a framework that we've used over many years in our work with states. And so now I wanted to kind of turn to the work that states are doing, acknowledging that every state is unique, and this chart kind of shows you how the situation around suicide is different in different states as well. But I think there are probably, over the past 8.5 years of working with states, some conclusions that I can point you to of some shared challenges and successes that states have in this area. And the first question that people usually ask is, well, where does funding come from for this kind of work? So I did want to mention a couple of things in particular from this list. The Garrett Lee Smiths and National Strategy Grants are SAMHSA suicide prevention grants that can go to states. Garrett Lee Smiths grants have existed for over 10 years now and are focused on youth 10 to 24. National Strategy Grants are newer and much a smaller program at this point, and they focus on prevention among working aged adults. But there are also other federal funding streams that relate to suicide prevention, including especially that recent MVDRS expansion. And states have leveraged other kinds of federal funding to support their efforts, and I'm sure Jared and Melissa may touch on that. But the other piece I wanted to point to is that many states have successfully obtained state funding for their efforts. In many cases, the State Suicide Prevention Office or task force and other infrastructure elements are embedded in legislation at the state level. So there are a lot of promising models there, as well as some other private areas that are still gaining momentum in terms of supporting state suicide prevention funding. So these are the big opportunities and challenges that I see for states right now in suicide prevention. And certainly Jared and Melissa will sort of give you some refinement on this. But really, at this moment is a moment of huge momentum in the suicide prevention field. We have new evidence that has helped to support the field's growth, and we have some really promising new approaches like zero suicide that really give us some potential for real impact. The challenge, I think, is that suicide is a really rare event, which is very fortunate, but that means the numbers are really small and it takes a long time to show reductions in rates for deaths. But we really need to, at this critical moment, sort of demonstrate that suicide is preventable and make that change, bend the curve. And so one area that a lot of people are looking into is how to get better attempt data. There are more attempts, and that may be sort of an earlier way to measure impact of efforts. And finally, I know I'm running a tiny bit long. I just wanted to tell you a little bit about some resources that might be interesting to you as state leaders interested in suicide prevention. There's the URL at the top for our online trainings that I mentioned before. I definitely encourage you to visit our state pages where we have contact information for the suicide prevention leadership in your state, information on currently active SAMHSA grants in your state suicide prevention plan, and much more. And hope you'll sign up for our newsletter if you're not already. And then I just wanted to point to two other key resources that might be of interest. In the middle there, the Framework for Successful Messaging gives you some more depth on the safe and effective messaging piece that I mentioned earlier. It gives you a lot of guidance and examples. And then I also wanted to mention the American Foundation for Suicide Prevention. They now have chapters in every state, and they are kind of that, at the national level, the advocacy arm for suicide prevention as a field. And many of their local chapters also work on advocacy for state legislation and support for suicide prevention efforts. So they can be a really important partner on the private side. And with that, I encourage you to get in touch with me at any time, and we'll have some time for questions after. But in the meantime, I will go ahead and turn it over to Jared Heinzman.
Great. Thank you, Ellie. Thanks to everyone for your time and an opportunity to present some of the projects we're working on in Colorado. You know, I have the pleasure of hearing about great programs in other states and at the federal level, and so being given an opportunity to highlight some of our work in Colorado is something I very much appreciate. And I will say, as an currently unfunded state from SAMHSA, SPRC is a great resource at the federal level. So to Ellie and her team, it's great to have access when we're looking for information outside of Colorado or things that are going on in other states. So certainly if you are not familiar with SPRC, they have people for each state that are main contacts, so I encourage you to use them. I'm going to talk today, I'm going to focus my comments on the working age male population, which we have prioritized in Colorado on a variety of different levels, and so I'm going to do my best to describe some projects that specifically target this age group, or projects that could better or should more deliberately focus on this working age population. And you noted, I'm sure, in Ellie's slides that males carry the burden for suicide deaths in the United States. And I would argue, this is true in Colorado and nationally, that there has not been a lot of funding set aside for anything outside of youth suicide prevention. And if our job at the national level and in Colorado is to reduce the suicide rate, and we've established some pretty lofty goals, including 20% reduction over the next 10 years, if we don't broaden our focus areas, we are not going to have success. And so that is part of my focus and priority on working specifically with working age males. So I'm going to dive in and certainly welcome your feedback and the discussion after the presentations today. And so we framed all of our work in Colorado, and particularly this first project that I'm going to describe called Man Therapy, around these notions of how we define masculinity and what it means to be a male. And I think this quote from Daniel Boone, it really sets us in the right direction, this notion of men, and I'm going to talk in broad generalizations, so please forgive me. I understand that lots of men access professional services and don't buy into these traditional stereotypes or definitions, but certainly this notion that men are less likely to access and seek care. Men are less likely to ask for help from something as simple as asking for directions, right? We want to figure things out on our own. to more complicated and serious matters, like I'm really struggling with something, but how I define my masculinity is a huge barrier for me acknowledging or accessing help related to some real struggles and some real important issues. And we know that men are less likely to report depression and less likely to seek help, particularly behavioral health help. So there's something in that, and it shows up in our data. And so looking specifically at Colorado data, and what you'll note right away about Colorado, and if you're from a state in the Rocky Mountain West, you have similar data to this, that our suicide rates are significantly higher in the Rocky Mountain Western United States. And Colorado's no exception. We always find ourselves in the top 10. So for example, our most recent year of data in 2014, that rate of 19.4 per 100,000 is far higher than the national suicide death rate. And unfortunately, that's the highest number of suicide deaths we've ever had in Colorado, and that rate is at a historically high level, and since 2009 we have seen an upward trend in our death rate. And so when you add that, or when you break it down and look specifically at men, it really highlights that in Colorado, and this would be true if you look at your state, I assume, and nationally, this demographic of working age men really carry the burden again, and our rates are essentially 2 times higher for men ages 25 to 64 than the rest of the population in Colorado. And so this demands that we be innovative, or we come up with strategies to better target this group, which is a hard group to reach, because as I said, it's a group that doesn't necessarily seek out or access traditional services. And this is not just about suicide. Men carry the burden for a variety of different health disparities. We injure ourselves or get injured more. We have higher rates of HIV and AIDS, more liver disease, heart disease. We have heart attacks more. We smoke more. We drink more. We have higher blood pressure. We certainly kill people at much higher rates than females do. And as the data has clearly showed us already, is that we die by suicide at much higher percentages and rates. And on top of all that, we're more likely to be uninsured. And so this is more than just a suicide or a suicide prevention issue. There's something bigger at play here. And so as we started this project called Man Therapy, we really looked at this 2007 issue of advancing suicide prevention that dedicated the whole issue to men and suicide. And these constructions, what I've called constructions of maleness, or how we socialize boys to be men. Some of these tenets that we really embrace maybe are barriers to and contributors to some of our public health issues. So this notion of no sissy stuff, certainly the notion that giving off any aura of any female, quote-unquote female trait is unacceptable. This demand that we be successful, and the status is incredibly important. We have to be looked up to, this notion of the big wheel. The sturdy oak, I'm tough, I'm confident, I'm self-reliant, I don't need anyone's help. And then this give them hell, and we see this in our violence data across the board. It's part of how we are hardwired. And so we really took that place to frame this project that we call Man Therapy. If you're not familiar with it, I strongly encourage you to take 10 or 15 minutes some point in the next few days to go visit mantherapy.org and just take a look around. It's a public-private nonprofit partnership between the Colorado Department of Public Health and Environment, the Carson J. Spencer Foundation, which is a local nonprofit in Colorado that does work all over the country, and then an advertising agency based in Denver called Cactus. Part of the richness and what's been so rewarding about this project throughout the years is the fact that what really makes it tick is the fact that it's public-private nonprofit. If you haven't looked at Man Therapy, when you do look at it, you're going to be surprised that there's a public partner associated with this project. And I'm really proud of that, to be able to represent a government organization that can partner on a project like this. And so the frame for this project is we have 3 basic goals. We want to change the social norms among men and the general population about how we talk about and view mental and overall wellness. And secondly, and critically important, is we want to empower men. We want to give men some strategies to take ownership of their mental health and overall wellness, so to change the frame of how we define masculinity. Not to say that you can't still be all those things on the previous slide, the sturdy oak, the big wheel, all of those things can remain important. But if you are struggling with a crisis or a mental health issue, you can't achieve optimum success on some of those things. And so being mentally healthy is critically important to your overall wellness. And so somehow we need to provide space for men to recognize and achieve that, and that's part of our goals with Man Therapy. And then finally, long term, if we have success, we certainly hope to reduce suicide thoughts and deaths among men. And so we've been working on this for quite a while. We did some research going into it while we were tracking down somebody to help us build and fund this project. And that research kind of led us to our basic approach. And I won't read all these to you, but some that really resonated with us. Very early on, we decided to land on using humor in a campaign that at the time was specifically a suicide prevention project, which I got to tell you, that was a risky and a bit of a scary move to use humor for a topic that, you know, is there's nothing funny about. But we really wanted to resonate with our target audience, which for us was those men that are not willing to access traditional mental health services regardless of the level of crisis or the level of need that they may have. And so how can we build something that engages those men that just aren't comfortable or refuse to access those traditional services? And that's what we mean by double jeopardy men, those men who exhibit the highest risk for suicide, yet are the least likely to access those traditional services. We also know that for many men, even if you provide and they have free access to behavioral health care, they're not going to accept it. So we also wanted to create a space where men could have an opportunity to fix themselves and certainly still provide opportunities if there's a crisis going on and someone needs immediate assistance to make that available, but also to create a space where men who are just starting to maybe struggle with certain issues or challenges can anonymously delve a little bit, dabble their toes into the waters of their own behavioral health. And so the other major factor that I just want to acknowledge is I think there's really important work going on in public health and work that I'm engaged in at my level in violence and suicide prevention in Colorado. I think it's important that we start to reframe or redefine masculinity so that we increase the capacity for help seeking and provide tools and strategies for how to reframe that. The reality is with this project, we chose instead to meet guys where they're at. So to utilize those traditional male stereotypes, not reinforce them, but use them to engage men in their own wellness. So we chose to meet men where they are, but I also want to acknowledge how important the work is to start to reframe some of our definitions of traditional masculinity. And so we built this website. If you visited it before February, it now has a different look and feel. We updated the platform in February, so it's now more user-friendly. You'll know probably that this is outside of my expertise, but it's a smart website. So it reads visitor behavior and feeds content based on that behavior. And we really drive the content the sorting of information in one important way through our 20-point head inspection, and that's it's a survey basically asking about behaviors related to suicide and depression, but also anxiety, anger, and substance use. And these 20 questions all are connected to that, and depending on how you respond to each of those questions, content from the website gets fed to you at the completion of that 20-point questionnaire based on how you responded to the questions. We also added, it used to be the 18-point head inspection, it's now 20 questions because the last two questions, one's asking if you are military or veteran, and the second asks if you're a first responder. And we also feed specific content if visitors suggest to us that they are members of those two additionally high-risk populations. And so again, go check it out. We're always interested to know what you think. We haven't had any marketing budget for this project from day one, and we've been, the website's almost 4 years since we launched. So we drive traffic through basic collateral, posters, coasters, business cards, social media, and it all uses humor with the idea of intriguing people enough that they see our information and say, yeah, I'm going to go check out that website. I'm totally intrigued by what this, men have feelings too, no, not just the hippies is all about. And the question we always get is, we have lots of anecdotal feedback. We have great Google Analytics with over 1 million visitors to the site since we launched. The question I always get is, well, do you know that it works? Have you evaluated it? My response for a very long time was, if you pay for it, we'll evaluate it. And finally, we established a partnership with the Colorado School of Public Health, the University of Maryland at Baltimore, and Florida State University to submit a grant to the CDC to evaluate man therapy in partnership with a program called Screening for Mental Health. We were awarded that grant, and so over the next 3+ years, there will be an in-depth and thorough evaluation of man therapy. So we will be able to tell you soon, which is great. Okay, in my last few minutes, I'm going to shift gears here and talk about another project. This is true nationwide. It's certainly a very hot and debated topic, but when we talk about suicide prevention, means matter. We know that males are more likely to use firearms in their suicide attempts. We know that firearms are incredibly lethal. So if you attempt via firearm, the likelihood is that you will die. And it's part of the explanation as to why men have higher suicide rates. Males have higher suicide rates than females because males are more likely to use firearms in their suicide attempts. And so we adapted a program. The New Hampshire Gun Shop Project is this great program that was developed in New Hampshire in partnership with a variety of different players. And we partnered with them about 2.5 years ago and said, hey, we love your program. We'd love to bring it to Colorado, make some minor tweaks, and start to roll it out here. And so that's what we did. I love this project because, one, we didn't develop it, but we saw that it was great. We saw that it could be done relatively inexpensively. And the graciousness of the New Hampshire partners to let us run with it, and a lot of other states starting to run with this, was really cool. And what's equally cool about it is the fact that we have found a middle ground in the very contentious firearms conversation. And the middle ground is we're talking about safety and not control. And the safety message is very, very basic. The firearms community, in my experience, which is a new experience, is hyper conscientious about safety when they talk about firearms. But what they are not familiar with, or less familiar with, is the importance of suicide prevention as a component of firearm safety. So the basic message is, if somebody in your house is suicidal and you own firearms, while that person is suicidal, you have to do everything in your power to ensure that they cannot access firearms. And this project partners with firearm retailers, with gun shops, firing ranges, firearm safety course instructors to get our message out to their customer base. And so we've started this project, and so there's brochures, there's information that we include with this project, including posters that, once again, this is another example of I never would have thought the state health department would have adapted and put out a poster like this one. But we're doing it, and we're doing it on a pretty rapid expansion in Colorado. So currently, the counties in Colorado with the green Colorado flags are counties where we are currently and actively implementing the Colorado Gun Shop Project. We're in 9 counties right now. All of those counties are rural with the exception of Mesa County on the western slope. So these are counties that there's high firearm ownership. And when we look at their suicide deaths, a significant proportion of their suicide deaths are firearms related. So in Colorado, for example, about 50% of our suicide deaths are firearms. In Montrose County on the western slope, about 83% of their suicide deaths are firearms related. So we followed the data and we partnered at the local level. It's not public health people like me who has no knowledge of firearms walking into gun stores saying, hey, will you use our information? It's firearm advocates who are also suicide prevention advocates who are going into the gun shops, introducing the project, and requesting their partnership. We've gained quite a lot of momentum and coverage about this project, and we just got some block grant funding from the state to expand the project to some urban counties, which we will do starting in October. So those counties with the blue stars are the counties where we will be expanding to. And of note, El Paso County, which Colorado Springs is based in, is in El Paso County. There's strong military presence in El Paso County, so we want to make that connection as well, which is very exciting. And so what I will leave you with, and as Ellie already described, and with the gun shop project, let me just frame that with men. We know that our audience in those gun shops, at firing ranges, and in firearm safety course classes are predominantly men, but we're also starting to target the women. There's one of our gun clubs in the Denver metro area has a monthly ladies' night, and a team of partners, which on the team of ladies on our team, went and presented at ladies' night a couple months ago, and really with that frame of here's how you keep your kids safe. Here are the things to look for if the man in your life is potentially struggling with a mental health crisis. And so I think that project specifically has the capacity to reach our working age male population. And then finally, the Zero Suicide Project, which is a healthcare project. I think what I'll add to what Ellie framed previously is that I think this is a great opportunity to target this high-risk population. In Colorado, we're starting our Zero Suicide initiative by partnering with our community mental health care system, because the reality is that's our low-hanging fruit. They're already aware of Zero Suicide. They're supportive of it, but the natural next step for us is how do we take this to primary care, and how do we take this to the emergency department settings and other healthcare provision settings. Those, to me, are the places where we'll reach these working age male populations. We'll also reach our older adult populations, and I think the great example of this with places that adopt Zero Suicide, the emergency department setting, to me, I think is so important, because one of the tenets of this, and one of the tenets of the Sentinel alert, the Sentinel event alert that came out from the Joint Commission, is universal screening. The recommendation that everybody that comes through the system gets universally screened. If we do that in the emergency department visit, even if it's a guy who's in the emergency department because of violence, there to get patched up because he got in a fight, required stitches, typically we wouldn't ask that person about their mental health or screen them, but if we do, we may find the underlying issues and may have an opportunity to intervene. And knowing that men traditionally don't access mental health services, what a great access point to maybe engage and better provide services for men who may be struggling. And so I'm really interested in delving into that component of the Zero Suicide framework. And so I'm going to leave it there. I always, on these national calls with our folks from outside of Colorado, I share pictures of Colorado, because Colorado is an epically beautiful place. And we are proud of the fact that in Colorado we are one of the healthiest places in the country. What we fail to acknowledge sometimes at the state level is that we're healthy physically, but boy, we have some troubles with things like our suicide rate and our substance abuse rate. And if our job is to be the healthiest state in the country, we sure better start dedicating more public health time, dollars, and energy to the topic of suicide prevention. It can no longer be a niche public health. We can no longer be the water polo of public health. Our data demands that we make this a public health priority. So I'll leave it at that. I'm going to turn it over to Melissa now, and thank you for your time.
Thank you, and I feel so honored to be asked to be part of such good company with Ellie and Jared here. And Minnesota, as you were speaking, Jared, it reminded me, Minnesota often ranks very high as one of the healthiest states, although one of the things we are frequently wanting people to remember is that even though we're one of the healthiest states, all of our people are not equally healthy. We have some of the largest disparities in health in Minnesota. So I'll be highlighting that with this presentation, which is in regards to American Indian youth and what we are doing in Minnesota to address our prevention needs there. So to start off, I just want to set the foundation for sort of Minnesota's public health approach to suicide prevention. So in September 2015, after having a public-private partnership task force at the state level, we released our Minnesota Suicide Prevention Plan, Goals and Objectives for Action from 2015 to 2020. And these are based on the national 2012 strategies And it actually was housed within the Health Department because according to our Minnesota statute, the Minnesota Department of Health coordinates the state suicide prevention plan, revision, implementation. And just for people who aren't familiar with Minnesota, like Colorado, we have Department of Human Services and Department of Health are separate entities, even though we work closely together. So while Department of Human Services funds a lot of the intervention, treatment, that sort of end, MDH is charged with sort of the prevention, but we really see prevention across the continuum. And so a big piece of ours is to make sure that we have a variety of state players involved so that we do have this sort of comprehensive public health approach, regardless of what agency or efforts or resources you bring to the table. A big piece that we tried to bring the lens of our approach in Minnesota when looking across the entire state and also in communities is sort of trying to look at a health in all policies approach, whether you're Department of Transportation building a bridge, if you're thinking about it not just for are there safe paths, is it going to stand the test of time weathering, but are we also thinking about it from the safety standpoint of possible jumps and those sorts of things. We also have the social ecological model, so we're looking at the individual all the way out to the community and society, trying to identify what people's roles are based on what they can do in those contexts. And then also the idea of looking through the health equity lens. The idea that a lot of our health is based on social determinants or our zip code or conditions such as access to care, but not just that actually, income, quality, meaningful employment, all those things that we are learning and talking about more when we think about prevention efforts. The thing to keep in mind is our state plan traditionally prior to the revision that we did in 2015, even though we had a across the lifespan state plan, we ended up a lot of our efforts were targeted at youth, and I think that's been true across the country, partially because of the funding, partially about what we know as far as good programs and other successes. But we realize that we have some increased risk groups, and one group that definitely has a high rate and a high burden, meaning the number in our state, is middle-aged males. I'm not going to speak about that today because Jared did such a good job talking about what Colorado is doing. The other group that we have identified as an increased risk group is our American Indian youth. So when we look at our state in general, these are a number of suicides going up since 2005. As you can see, we've sort of about 683 in 2014, 683 in 2013. So we're almost to 700. We used to be below 600, like 550 in 2005. So just 10 years ago, we've had quite an increase. It is the 8th leading cause of death in Minnesota in 2014. But if you actually look at our ranking for our state, we are below the national rate for suicide, and we're pretty actually, I think like 40th or something. It bounces around per year, but we have a pretty low rate for our suicide. Again, though, if you look at certain populations, we don't look so great. So if we look at Minnesota's suicide rate for this time period, and this rate is per 100,000, you see American Indian, all ages have a higher rate than whites, followed by Asian Pacific Islanders and blacks. If you go though and look just at that age group of 10 to 24, you can see the significant disparity we have with our American Indian community. This is a 5-year set of data, and just to kind of give you a scope of it, even though their rate is over 30 per 100,000, the total number of American Indian youth in this age group of 10 to 24 across these 5 years is 33. So if we work really hard, which we're going to do to eliminate and prevent these suicide deaths in the American Indian community, it is going to make a huge difference as far as what we build for infrastructure in those communities and their future. But we have 683 per year. So to really address the burden and the rate at our state level, we're going to also in conjunction need to be doing stuff for our middle-aged male population. Okay, but specifically to American Indian community, and the youth, we have 11 tribes in Minnesota. They make up just a little bit of over 1% of our total population when we look at American Indian alone for race, not American Indian and other races. And in this community, it's the 7th leading cause of death, where it's 8th for Minnesota residents total. Some things that are very different with our American Indian community in regards to suicide compared to the rest of sort of our state is they're younger ages, and not just younger ages, we have younger ages. So if we're going to have a death potentially by suicide that's at 10 or 11, it seems to be disproportionately happening in our American Indian community. The other thing is we have a significant issue with contagion and clustering in the American Indian community. There seems to be a lot of connections among these members, these youth throughout the state, even though they may be in totally different parts of the state. There's a connection, a familial and relationship connection, where if a death occurs, it's sort of, I say, it sort of echoes or ricochets throughout communities, so that each community sort of hears about this death of a young person, and it sort of re-traumatizes and sort of brings up a lot of healing that hasn't happened. And so it can be very difficult because we do hear from communities, especially in 2013, we heard increasingly from communities saying they thought that they had a lot more youth suicide and attempts among the American Indian communities. And it was really hard because we would get a report and no one really knew all the details. So you didn't know if you were getting a same death reported 4 times, through the phone calls, or if they were 4 separate deaths. There was a lot of concern around pacts. Pacts are really hard to really get at the root of if a pact really was in place, and are those youth that were part of that pact, what is the risk and who's wrapping around them? And there's a lot that goes with the youth that are left behind if there was a pact and one dies by suicide, a lot of guilt that they weren't the one who died. There's just so much at play, and they're such young children. So contagion can really be a problem in this group. So we started having communities request some state assistance to begin to have tools in place to address the potential contagion, the increase in attempts, and what they should do. So in 2013, for American Indian community, all ages, we had 23 suicides. And typically we have about 10 or 12 that are reported a year in our vital records. So we had almost a doubling. And the doubling primarily, the most of those cases came from our 10 to 24-year-olds. They had a rate of 46 per 100,000. So it's a small n, but you can imagine the impact in that community. And that just addressed the deaths. There are a number of reports during this 2013 of increased attempts in the communities and a lot of other sort of issues that are hard to measure with the statistics we have. So what did we do in Minnesota? Well, we were in the process of sort of convening our task force to address the state plan, but in the interim we needed to address the community's requests. So we pulled together a state agency work group, because what would happen is the Department of Ed, if there was a suicide in the community, Department of Ed would get an email from the superintendent or the school. Department of Human Services would get an email in regards to sort of what's available for trauma support or crisis. And then the health department would be sort of asked to come and do a bunch of trainings, even though really when a death has occurred, we don't want to just come in and start doing a bunch of prevention stuff. We want to do a lot behind the scenes to coordinate and allow the community to heal and move forward, and then sort of be more thoughtful about our prevention efforts down the road. So the neat thing about these 3 agencies coming together was before this, there was no working group. So each person who had the role or got contacted within each agency sort of responded. Well, that's really difficult to coordinate at a local level when they're all getting different resources or different information. So we began communicating together and making sure we had a community response, a coordinated response to the community. Each of these departments listed here have their own tribal liaison. So for example, Minnesota Department of Health has a Director of American Indian Health and a tribal liaison, with the idea that they will help the staff who work in these topic areas have a working and improved relationship with the tribes, the 11 tribes in Minnesota. Because each tribe functions differently and has different resources and everything. So they really are the conduit to us to make sure that we are responding in a culturally appropriate way, that we have the right role. A big part of working with the tribes is we have to be asked by the tribes to come and be involved, which that determines the level of action or involvement we can have. And so they were really helpful to make sure that they're orchestrating all of those pieces so we're not getting lost in those as a topic expert, but we're able to sort of work with them to say, okay, this is what we need to tell them. Can we work? Who should we be talking to, and can you help me figure out what the best way to word that is? And I learned a ton through it, and really I would say we have greatly enhanced and improved our relationships with different communities in regards to how to address this and other issues. So in addition to this sort of being able to be more planful in our response, we determined that so many communities were being re-traumatized and they needed some support for postvention. So how do you respond after a suicide? So the three state agencies came together and we brought in Connect Suicide Postvention Training from New Hampshire NAMI. It was just the greatest thing because we were able, all state agencies played a role. All three kicked in money for suicide prevention training. This typically doesn't happen. We have state funding for suicide prevention, no federal funds, and those state funds go to Department of Health. They're very limited, but each of these agencies realized they had a role and they needed to put some money into this issue. So we did one postvention training for just tribes, so they could send a team that represented both prevention and human services. We also had our state agency folks there, like the tribal liaison, so they understood what postvention was. And then we have some larger nonprofits and education programs specifically for American Indian youth that we also included in our training. And the ultimate goal with this and all of our efforts with our state plan right now is to build local capacity. We really need the communities, even though these are relatively rare events, which is a good thing. Their impact is so immense, and each community has different risk factors and different resources and assets and different key people and different cultures and all of this that we want to really wrap around the community so they feel competent and comfortable handling this and other issues so that going forward we have more sustainability. One of the things that we kept getting requests with the postvention is, don't you have a rapid response team at the state? No. I mean, I was half-time. I'm it. This is the statewide suicide prevention coordinator, half-time. Even if I was full-time, it really doesn't make sense. I would be coming in and learning so many things that the community can already know. I would be, maybe there was a death anniversary and I wouldn't know that, and there'd be so much on the upswing to understand that the more we can sort of help communities build in this capacity, the better response they're going to have, timely and effective, than if we had some group come in and try to orchestrate what should happen in the immediate death. So just to kind of reinstate what I said, so before when all this was going on, we had $98,000 for community-based grants. These were primarily focused on youth. They were sort of statewide agency efforts. They did not have really true culturally appropriate American Indian grantees or efforts in place. But in 2016, we got an additional $150,000, which more than doubled our grant dollars. And what we did is we released 2 RFPs that were earmarked specifically for American Indian communities, and I'll show that later. This was the first time we had done that. In the past we said, address increased risk populations, and people, I don't know if you've ever reviewed RFPs, but people all of a sudden are best friends with whoever you are going to target without a lot of capacity there to address it. So we really did not want an organization that really has been doing a lot of good work and has suicide prevention institutional knowledge all of a sudden try to be culturally competent. We really wanted it to be based in the community and they gained the suicide prevention knowledge to address their issue. So the other thing that came out of this is rather than having a half-time coordinator, we now have a full-time coordinator. So that's why I've transitioned roles. But it's really going to help support all of our efforts, not just with American Indian communities, but throughout. So two of the programs that we funded, I'm almost out of time, but I just want to highlight, I think I only have a couple of slides, is one of our communities, Lower Sioux community, Dakota Wichahan. They applied to do a very resilience-based program around protective factors, positive messaging, and have a component in there to provide technical assistance to other communities who want to work with tribal communities, how to do that in a very positive messaging and resilience-based approach. So not only are they going to build the capacity of their own community, they're really going to try to help other communities who want to work with American Indian youth to build their capacity culturally. The other group is White Earth Mental Health, which is one of our tribes. They are doing gatekeeper training and postvention training within their community by tribal members. And then the other thing we were able to do to sort of enforce and support communities is our Lower Sioux community. We had a grad student intern who did the community readiness manual or assessment with their tribe. And really, she was Native herself from Arizona, and she really enjoyed the opportunity to get to know another tribe and how they're different and similar. And she was able to do this community readiness assessment with them and really help them sort of design what are they ready to tackle next. In the process of this assessment, though, they had a youth suicide, and so the community was really sort of healing throughout this, but really was excited to kind of wrap around this and see where they could go to move forward. Oh, there's my timer. And then, so one of the things that we are going to be doing at the health department that came out of this assessment is to promote more use of the community readiness model so that we're really making sure that it's rooted in the community where the community's at. It's not this state level thing that we're kind of pushing down on communities, do these trainings or do this effort, that the community really gets to decide what that is. And one of the pieces that we have heard may come out of this, that we've heard consistently with a lot of our tribes, is the idea of the youth being hopeless and really wanting meaningful work. And if they did a community readiness assessment and wanted to do it on something other than suicide prevention, but was it one of these protective factors, I think MDH and our state agencies would be fully supportive on that, knowing that that's going to enhance and support them to prevent future suicides. So in summary, our next steps through the Department of Human Services, which does our mobile crisis response, that they have set aside funding specifically for tribes, first time ever. So I think we have 3 tribes that now have specific mobile crisis teams with their own tribal members that they are getting up and running. They're also expanding one of our hotlines that's through a tech services to target specifically tribe communities and try to train their staff at the tech center to be more culturally appropriate and know the resources on the tribes. And then at our health department, we are doing more to promote our gatekeeper training, social conditions and health equity lens through a lot of our conversation, promote the use of the community readiness model, so we really know what makes sense for that community. And then we also are, which is my new hat, working with our Minnesota Violent Death Reporting System to really try to look at populations in more detail to understand what circumstances that led to the suicide just prior to, so we can do more interventions and try to really make it as local or culturally appropriate as possible. So that's our exciting work. So now I can hand it off.
Okay, great. Well, thank you all so much, all 3 of you. That was a lot of great information in a short amount of time, and I appreciate the effort it takes to provide that kind of information that way. So we're going to now open up the Q&A session to all the participants. If you want to ask a question, please continue to type them in. We've got some good ones in the chat box. But we'll also ask the operator to let us know how to unmute our phone line if we want to ask a question that way. Operator?
Ladies and gentlemen, if you would like to register a question, please press star followed by the number 1 on your telephone keypad. If your question has been answered and you would like to withdraw your registration, please press the pound key. One moment for your first question.
Okay, and I'm going to go ahead, operator, while we're waiting on that question. And we had some really good questions typed in the chat box as we were going through the presentation, and we had some of you all send them in ahead of time. So we've got a few questions to start in case we don't get any call-in questions. So first of all, I'll start with one that was a short question. Let me also say that the questions we don't get to will respond back in writing to the group. So one question was, and I think I'll ask Ellie if she'll respond to this, does assisted suicide at the end of life count in these rates that you spoke of in your presentation?
Yeah, my understanding is for those states in which physician-assisted suicide is legal, that those deaths are not counted as suicides. Instead, they're counted as deaths for the underlying illness, since people have to be very severely ill in order to qualify. So no, the short answer is no. It's my understanding that assisted suicide is not included in those numbers.
Okay, thanks. And we had a question from Adam Hoffberg about the zero suicide law that was passed in Colorado, and Ellie touched on that, and so did Jared. So what I'd ask Adam to do is, if you could type in anything else more specifically that you want, I'll come back to you after we get through the next question, if that makes sense. Another question was, and I'll throw this open to the group, what's the status of suicide prevention training being a requirement on license renewals? Do you know how many states currently do that and how many have yet to make that a requirement? So I'd ask, I guess, Jared and Melissa to say, is that it's something that happens in your state, or what do you know about that? And then Ellie to chime in at the end if she has a sense of the national field of that.
Yeah, thanks, Kathy. This is Jared. I think Ellie probably is best equipped to answer that question. I will say in Colorado that we've explored it, and we got a pretty resounding pushback from the professional organizations around licensing. We don't have any mandated specific training for licensed professionals in Colorado.
Right. I think that's for people to hear kind of what the reality is of when you try to do that. Melissa, anything to add to that before Ellie finishes us up?
Yeah, so for our mental health professional license, we don't have any of that, but we just got passed a law. It just went into effect that the teacher license renewal, they have to do, I think, 4 hours. That one of those hours has to be suicide prevention, but there were no guidelines or clarity about what that needed to be contained within that. So we are trying to work with Department of Ed on their roll-up to make sure that it's not just a random speaker coming in, but that is a new initiative in our state.
Thank you. Ellie?
Yeah, I'm glad you mentioned that, Melissa, because I'd say that kind of law requiring teacher training is much more common, and I don't want to say anything that's totally wrong, but I'm fairly sure that the majority of states actually have some kind of requirement for training of school teachers and or staff in some way, and often that does happen. The legislation goes through, and then it's not entirely clear what training is supposed to be used. So sometimes a challenge for suicide prevention folks. But in terms of licensing for healthcare providers, or not just mental health, but in some cases other providers, there are 5 states as of my most recent sort of update that I have available. It started in Washington State. I'm sure many of you saw that in the news. And now Kentucky, Utah, New Hampshire, and Nevada also have similar bills. There are different kinds of conditions, different kinds of hours of training required, and different kinds of professionals who are included. And in fact, Washington went back after the initial law to pass a second law to expand the professionals who are covered under the requirement.
Right. Thank you very much. And Teresa Hansen just did type in about Washington and that it is teachers and several other health professionals. So that's great. I hope that answers that question. One other question had to do with the information that Jared presented about men being more at risk for almost all deaths and less likely to seek help. What would be you all's thoughts about why we don't see more funding for school programs to teach seeking and healthy coping, and what a good time that is to plant some seeds and reach some folks before they develop some other habits. So Jared, I guess I would turn to you and see if you have any thoughts about that, and then ask either Ellie or Melissa if you have any thoughts to chime in.
Yeah, thanks. I'll just say it's a great comment. I think it's absolutely a place where we should better emphasize some of the work that we do and some of the work that we connect to suicide prevention. The Centers for Disease Control and Prevention's recent document called Connecting the Dots, I think really hits this point around the notion of shared risk and protective factors. And I think a lot of that work needs to be emphasized in our youth suicide prevention approaches, and we are certainly emphasizing that in Colorado. We've made, the Office of Suicide Prevention in Colorado has made a school-based program called Sources of Strength a priority of our office. And the reason we selected that program, one, it's an evidence-based approach, and two, it's a primary prevention approach that focuses on positive youth development and resiliency, and the things that it impacts are shared protective factors. So we've really focused on things like school connectedness as a measure we want to impact, connectedness to caring adults and to positive peers. Those are protective factors for more than just suicide. They're protective factors for bullying, some for sexual violence, for teen dating violence, and so by emphasizing building those skills at a younger age, we have the potential to impact multiple public health problems, and so it's absolutely an approach that has to be more emphasized in my opinion.
Mm-hmm.
Melissa or Ellie, do y'all have anything to add, or you want to press on?
I think Jared said it well. We currently don't have funds to support sources of strength, but I think programs like that are essential for us to really address this across, from a person's life throughout, that they have
Okay, great. Thank you. Ellie, let me ask you if you would chime in on one of these questions. Could you give us just a little more information about the attempt surveillance data and good resources on that?
Yeah, and there are definitely resources, but probably I won't be able to answer the full question just on the phone. So we could maybe, if we're sending written comments, provide a few links. Probably, and Jared and Melissa, please jump in, because the innovation is really happening on this at the state level, I feel like. There are a number of states that have been looking at their hospital association data for hospitalizations for self-injury. So those are probably medically serious attempts that require people to be hospitalized for the medical treatment. So that's one source that people are using, but people also go to the emergency departments and aren't hospitalized. So that's another important resource, and there are a couple of examples of states working with emergency departments, particularly at the local level, to try to get information. And then the other kind of piece that doesn't capture are attempts that don't require medical treatment. And for those, you could look at the Youth Risk Behavior Survey, or the BRFSS, which is the adult equivalent, to try to, no, sorry, not BRFSS, the NISDA that I showed you the slide for with the women attempting more frequently. They do ask about attempts there and thoughts of suicide, but there's some limitations in each of those data sources, and I think the challenge is to sort of put all those pieces together in a reliable way. And also because it's medical information in the case of EDs and hospitals, there's not as much information you can get about the person, whereas when Melissa's working on the violent death reporting system, there's all kinds of very rich information about the person's marital status and whether they had a mental illness or a substance abuse issue, had they been involved with legal troubles, etc. So there are some resources, and we can maybe include some links, but I think it's still an area where we're learning how to put all those pieces of the puzzle together to get something reliable and useful for planning. I don't know if Jared and Melissa would. Melissa, you're the epidemiologist. now with the new hat. So.
Well, no, I mean, in Minnesota, we have the Minnesota Injury Data Access System, Minnesota MIDAS.
Mm-hmm.
And we have included in there both the injuries, so you've actually needed medical treatment, whether ED or hospital for your injury of your attempt. But we also include in there the broader definition of self-directed violence. And so your numbers are different, but because they include more than just the injury part of it. So we have a query system online where we're trying to make that data available, ED hospital. And then we also use our hotline and mobile crisis data. Our mobile crisis and our Text for Life data, they list the primary reason that they were called or asked for service, so that we can tease out how much of it was really suicide, suicidal ideation versus all the other sort of crises that occur. So we've been trying to look more at that. The part that's hard about that is you have to know those numbers exist to use them, but we can try to see if there's some sort of something we can pull out of it. The problem that we have when we look at our American Indian youth is we don't get race on any of those at this point. So we can't really tease into that piece more. But we are looking at our EMS data, and we're trying to explore that also. That might be a source for people too, if they have state trauma data or not.
Okay, well, along that line, we had one that was just typed in kind of along this same line is, do you all have any thoughts you want to share about how people are collecting data from hospitals regarding attempts? We kind of just touched on that. We might have answered that. Do you have anything else you want to add? It's just a question about how you collect data from hospitals about attempts and deaths.
This is Ellie. Just 2 quick points. You can, in most states, you can purchase from your hospital association at the state level the data about hospitalized attempts. However, that data is really labor intensive to clean and analyze. If your state participates in the HCUP system, which not all states participate in, that is a federal database that can be accessed. And if your state is participating, they've sort of cleaned the data and you can run reports a bit more easily. So that's my understand. That's about where my understanding ends. I don't know if Jared or Melissa had anything to add.
Well, along that same line, I'm gonna press on because I want to. Some of you all were great to also send in some questions ahead of time, so I want to get to at least a couple of those. And Jared, if you had anything to add about that data, you please feel free to do it. But let me ask you another question. There are a lot of shared risk and protective factors that intersect between suicide, mental health, chronic disease, and early trauma experiences that also is known as ACEs. Are you, and do you know if states are leveraging their ACE data to improve their work on mental health and suicide prevention?
Yeah, thanks, Kathy. I don't have anything to add about the hospital data.
Okay.
We actually only very recently added the ACEs module to our BRSSS questionnaire, and so we don't really have Colorado-specific ACEs data. We just use the national data. It's so well researched and well established. But I think it's a real key to some of our, what as Ellie described in her presentation, a comprehensive approach to suicide prevention. I think for too long in Colorado, I'll just speak for Colorado, we've been guilty of focusing only on suicide prevention, and we stick in our suicide prevention silo. And now I think is a great opportunity to expand that, because there's really great work going on in early childhood. And we know that adverse childhood experiences really contribute to adverse health outcomes in adulthood. And so how do we better align our efforts or simply utilize the great work that's going on in primary prevention or early childhood focused prevention efforts, things like child maltreatment? In my opinion, one of the things we can do that could potentially have great success is simply to add indicators to that work in the field to see what long-term impacts there are to those programs. Because in my opinion, that is suicide prevention. Because if you can prevent a kid from experiencing child abuse or neglect or other types of trauma, that kid has a lower risk for suicide later in life based on those data. So I think it's just better integrating the work that we do at a public health level on a comprehensive approach level.
That's great. Thank you. That's helpful. So while I've got you, I don't know if there's anything you wanted to add at all or expand a little bit about what you said on the suicide law in Colorado. Anything more particular that you might want to add?
Yeah, I'll just say, and I meant to address it in my presentation, so I appreciate the reminder from Adam, I believe it was. So on last Friday, Governor Hickenlooper in Colorado signed Senate Bill 147, which is a zero suicide bill that encourages, so there's no mandate involved here and there was no fiscal note tied to it, but it strongly encourages the healthcare systems in Colorado to examine and adopt the zero suicide framework. So that will allow us, and so my office is charged with administering that law and coming up with a plan for the state for the adoption of zero suicide, or what we're calling the Colorado Plan. And so it will allow us to better connect with and engage new partners in the healthcare fields in encouraging them to adopt the zero suicide framework. And I also think it'll help us align with other efforts like our state innovation model, which is focused on integrated care to emphasize suicide prevention because of this law. So it's an opportunity for us, I think, to leverage political will for suicide prevention.
Great, thank you. Let me move on to another question that was called. Oh, I should ask, I've been derelict in this. Operator, have we had any calling questions on the call, on the calling callers?
There are no audio questions. As a reminder, to ask a question, it is *1.
Okay, great. Thank you, operator. I'm glad no one was holding on this whole time. Let me ask another question that came in. We've talked about several different ways to address suicide prevention and outreach to specific at-risk population, but we have other folks that are kind of interested. Do you all in your states or Ellie nationally know about any folks that are involved in programs targeted to individuals that are in a college setting or also LGBT youth? So I'll just throw it open to you guys.
Ellie, do you want to take it from campus? Or?
Yeah. Well, for campuses, part of the Garrett Lee Smith program is a campus grant program. So there have been hundreds of colleges and universities that have been funded since 2005, and SPRC provides the technical assistance to those campuses. So we do have a very, very rich array of resources on our website, and that's one of the settings that you can find there. I do also know of states that are doing statewide work, so where state agencies are sort of involved in initiatives for campuses across the state. I believe Missouri and Virginia have done work like that in the past. I think Virginia is still doing that. And the current Pennsylvania State GLS grant is also focused on college campuses. So those are broader efforts bringing multiple campuses together to share experiences and best practices. But I definitely encourage you to check out our website. And we also have a lot of resources on work with LGBT populations. But I don't know if Melissa and Jared want to mention anything specific that they're doing.
Melissa, anything to add?
No, I don't at this point.
Okay, Jared.
I'll just do a very brief shameless plug for my friends on the Man Therapy Project. A new tool that has come out and is available to college campuses is called YOU, and it's a digital platform to support. It's basically a mental fitness center with tools and resources built to match the heartbeat of student life. So to get just a sense of what it's all about, it's gritdigitalhealth.com. And you can get more information there. It's a brand new resource that a couple of campuses have already adopted.
That's great. And if you can be sure, Jared, and send that in to us at ASTHO, then we can put it in the notes with some of the other links that Ellie was talking about earlier when we respond back out to those that were on the call. So that'd be really helpful if you could. And I think that information, particularly now after this horrible weekend, when you worry that people might be even more susceptible to perhaps thinking of suicide, that kind of link and that kind of help would be really helpful. So with that being said, I'm looking at our time, and operator, let me check. Any calls? Any questions in?
No, ma'am.
Okay, that's great. So I guess I think we've kind of touched on most of these other questions that were written in. So I guess I would just ask our presenters, if you have any last-minute closing thoughts or things you wish you had shared, or pleas to the group before we close today. So Ellie, I'll start with you.
Just so glad that so many people joined us, and I do encourage you, if you're not already connected, to reach out to the folks in your state who are leading these efforts. It's a very broad issue in many ways, and so it's not only owned by the mental health agency in state government, but also lots of private stakeholders. And so please feel free to get in touch with your state person, but also SPRC. We're happy to point you to resources, information, tools to help you really develop new initiatives that are right for your state, as Jared and Melissa have modeled so well, sort of using those pieces of the strategic planning approach, the comprehensive model, and those keys to success.
Great. Thanks, Ellie. Jared?
I just want to thank everybody for their time and attention. And any information from my presentation or what's going on in Colorado, I'm happy to share. I'm also always happy and love to hear about what's going on in other states that we could benefit from at our level. Welcome feedback and suggestions based on what I've talked about today. That would be very helpful. Thanks.
Thank you, Jared. Melissa?
Yeah, I just also want to thank everyone. It's not like everyone's favorite topic to discuss, so I appreciate people chiming in and sticking with it. The other thing I want to say is I think it's sort of exciting that 2 states that were highlighted are states that aren't currently funded with federal funds, and even though we probably would be more than happy to have those funds, I think it's important to remind states that there's a lot you can do without external resources, and just sort of leveraging them and working with your partners within your state, whether state agencies or nonprofits. You can do a lot.
I apologize, but the sound is bad. Are y'all hearing?
It's sort of dropping in and out for me.
Yeah.
There, thank you. If I'm still on, if the quality of the sound gets bad again, I'll just ask one of the ASTHO folks to pick up. But let me just say thank you so much to our presenters today. Let me say that if you have questions that you think of at the end, please send those in and we'll get them to our speakers. We appreciate so much the participation during the call. More information about the Payment and Delivery Reform Technical Assistance Call Series will be on our website, on the web address that you see on the screen. We'll have a recording of today's webinar in the next few days, and we surely do hope that you use this as a resource, and we'll share the link with others once it's available. Please mark your calendars for the 4th call in this series, which will discuss how community development sectors can serve as a partner for health equity, and it'll be on Tuesday, June 28th. Registration for that call will be posted on the website seen on your screen. As we mentioned earlier, you're going to be getting at the end an evaluation link, and we hope so much that you'll just take a few minutes to complete it, because that's how we plan our future work. I want to thank CDC for sponsoring the call, and also our speakers. What a great conference call. We got so much good information, and we're able to share so much about what's going on in the states and also get that national picture. So thank you, Ellie, Jared, and Melissa again so much. If you have any follow-up questions about today's webinar, call or contact Kristen Rigo at ASTHO. And thank you so much, and enjoy the rest of your day. Goodbye.
Ladies and gentlemen, that does conclude today's conference call. We thank you for your participation and ask that you please disconnect your line.